Muchas gracias al doctor José Juan Ta por su extraordinaria conferencia. Me sonrío porque hace muchos años atrás, cuando hice mi primer posgrado de cirugía general, de mis grandes queridos profesores decían que ellos jamás se operarían por cirugía laparoscópica que se estaba haciendo en esa época. Hoy en día son grandes maestros laparoscopistas y se convencieron de que esa era la metodología adecuada para operar la vesícula por laparoscopia. Quizás para nosotros los que hacemos cirugía de cabeza y cuello, en algún momento este sea el gold estándar para poder. Muchas gracias, Josía, por tu intervención. A continuación me complace nuevamente presentar a nuestro querido maestro, nuestro querido mentor, el doctor Shaha, que nos va a hablar sobre un tema quizás controversial, pero que sigue estando en el tapete y en la discusión. Esta patología de carcinoma diferenciado de tiroides, hablamos si se hace disección o no se hace disección en el compartimiento 6 del cuello. Y está la polémica y el equilibrio entre la calidad de vida versus la curación de la enfermedad. El doctor Shaha, como lo presenté anteriormente, es el jefe de servicio del Memorial Sloan Kettering Cancer Center de Nueva York. Es expresidente de la IFNOS, miembro permanente del consejo de la IFNOS, es un líder conferencista a nivel mundial, mentor, amigo unido a nivel mundial, miembro honorario de más de una docena de sociedades científicas a nivel del mundo y tiene muchas premiaciones no solamente en el ámbito médico, sino fuera de él. Él nos va a conversar sobre disección del nivel 6 en el carcinoma diferenciado de tiroides. El presente, nuevamente, doctor Shaha, es un honor para mí tenerlo con nosotros en el día de hoy.
Once again, thank you very much for giving me an opportunity. Dr. Mihares, we appreciate, and I appreciate the kind invitation to give these talks. I just finished talking about the contentious issue in the management of thyroid nodule and thyroid cancer. I'm going to change it now to the dissection level 6, present and future. I'm going to add a little bit to that, the classical past, present, and future. And I'm going to give you the whole reasoning about this debate. Sometimes I feel we debate in thyroid for the sake of debating. It's like debating with your wife, you know. You both of you have the same goal, same direction, but you just go parallel to each other. Why? Again, surgical philosophy, dogma, and experience. And I will illustrate that in the management of thyroid cancer, especially level 6. Recently, a few years back, we published from the American Thyroid Association consensus guideline. There has been consensus about central compartment, the lateral compartment. I was the co-author on this publication. And you cannot give a talk anytime without showing one of your own publication and your name in the slide. Okay, I'm going to go to the basic principle and then I'll come to the contentious issue of level 6. The number 1, the lymphatic drainage of the thyroid is rich. Number 2, the presence of lymph node metastasis is very high. 40 to 70% of the patients with thyroid cancer will have nodal metastasis. It may be the central compartment, and in about 20 to 30%, it may be the lateral compartment. Now keep in mind, the debate about central compartment is a young debate. And I'll tell you when it started. It started in 2006. In a minute, I'll show you how it started. But we never debated about neck dissection or central compartment. We just went in, we took out the thyroid, we looked at abnormal lymph node, they look abnormal, we took them out. They didn't look abnormal, we leave them alone. We're never worried about the microscopic metastatic disease in the lymph node. All the debatable literature on the nodal disease is of last 2 decades. And I have been in the practice for 3 to 4 decades, and we never argued about it in the past. We just followed these patients, we examined them, we didn't do the ultrasound, and they were happy, we were happy. What happens in medicine? We find the new investigations and we get annoyed about it. We follow that investigations. So keep in mind, 40 to 70% of the patients have nodal metastasis, and there may be multiple groups of nodal metastasis, but the outcome does not change. These are the lymph nodes in the central compartment. The nodes along the jugular vein are lateral compartment, and the classical compartment system was developed at Sloan Kettering back in maybe in 30s, 1930s. So it is very important to realize that there is an evolution in the staging of thyroid cancer based on nodal metastasis. In the seventh system, it was 1A and 1B. And the 1B was level 7 node metastasis, which puts the patient into stage 4. That was not correct. I think that was not right, especially in the patients with low risk group. From stage 1, they immediately jumped to stage 4 because the level 7 nodal metastasis was found to be positive. Now it is included as one group in N1A and 1B. And this is the major change in the next staging in 2018. The N1 disease, as I mentioned to you, is now more critically analyzed as N1A and N1B. And N1B is now not a stage 4 cancer. It is stage 2 or 3, depending upon the age of the patient. And to me, this is a major change. And that is based on the biology of nodal metastasis of thyroid cancer and the overall outcome. So everybody who is involved in the nodal evaluation should be familiar with the new staging system. And this is again the 2001 publication. I was a co-author on this publication with Tom Robbins. This came through the efforts of the AAO-HNS and AHNS, developing the sub-leveling of the levels of the neck nodes. Now we at Memorial had popularized level 1, 2, 3, 4, and 5. Now it has been subdivided into 1A, 1B, 2A, 2B, 5A, and 5B. Now, initially, there was a lot of debate. Are we making simple thing more complex? But I think with the understanding of the nodal metastasis and the regionalization of the nodes in the neck, I think we have become smarter. You know why? Because now we don't use radical neck dissection as a usual treatment approach, even in squamous cell carcinoma, definitely in thyroid carcinoma. Now, why is it important? Level 1 nodal metastasis is quite rare in thyroid. Level 2B, above the accessory nerve, again quite rare. And you don't need to dissect unless there is a bulky disease here. Because the more dissection you do, the more nerve weakness you are going to see. Again, what is important is maintaining the best quality of life of these patients. Very important. Level 5A is quite rare in thyroid cancer. The bulk of the nodal metastases are at level 6, which is the subject of this debate, and level 4 or the low level 5, or the what we call classically supraclavicular lymph node metastasis. Now, before I go on to the debate, I want to show you this slide. The prognostic factors in thyroid cancer have been studied all around the world. The Memorial, the MSKCC, the Mayo Clinic, the Leahy Clinic, the Karolinska, and many other institutions. There are approximately 25 different systems of thyroid prognostic factors. But if you look at all these prognostic parameters or risk group analysis, you will learn one thing. Nodal metastasis is not included in this risk stratification. Very interesting. And I told you in the previous talk, the nodal metastasis is the most important prognostic factor for other human cancers, not for thyroid cancer. Excuse me. And you will see here amongst all the prognostic factors, the age, the grade, extrathyroidal extension, completeness of resection as popularized by Mayo Clinic, and the size of the tumor. Nowhere nodal metastasis is included. Go to squamous cell carcinoma or lung cancer. Nodal metastasis is the most important prognostic factor. And as I mentioned before, this is the biology of thyroid cancer. And this is so important when it comes to the debate about management of level 6 nodal metastasis. The preoperative evaluation is very important. In the last talk, I talked about the CAT scan, but to me, the CAT scan is a very important investigation because it gives you the third dimension of the tumor. Its closeness to the vital structures, the trachea, the esophagus, the carotid artery. So the CT scan is very important, and I like CT scan than MRI because as a surgeon, I find it true anatomical evaluation, and I can get the understanding of the extent of the disease and the third dimension of the tumor. The fine needle aspiration biopsy with cytology and occasionally with thyroglobulin wash is very important. And the CT scan is also very important to evaluate the recurrent thyroid cancer, the parapharyngeal and retropharyngeal lymph nodes. It is most important in medullary cancer to look for the paratracheal disease at level 7 and in the superior mediastinum. This is a classical example. This patient presented with a bulky nodal disease here. We got a CAT scan and you see here a bulky nodal disease. So now the patient is prepared for the appropriate surgical procedure and its ramifications and complications. This is one of our old slides. I like to show it because we published this almost a decade, almost a quarter of a century back. And what it will show you here, the nodal metastasis or no nodal metastasis, the same outcome. Very interesting information, and this is something we need to keep it. Now, don't misunderstand. Every nodal metastasis is not good, and I'll show you what is not good. When you take the older patients above the age of 45 in the old staging system, or now 55, you will see here there is some statistical difference in the long-term recurrence, outcome, and eventual mortality. So thyroid cancer nodal metastasis is not good if you have aggressive thyroid cancer, bulky nodal metastasis. So where is it not good? If the number of lymph node metastasis is more than 10, you will see here the recurrence of 20%. As a matter of fact, if the patient has 15 positive nodes, the risk that patient will recur is extremely high, more than 20%. And the risk that patient's thyroglobulin will go up is also quite high. So the number of nodal metastasis is very important. If the nodal metastasis is more than 3 centimeters or there is extra capsular extension, take a look here. More than 3 centimeters with extra nodal extension, the risk of recurrence is 32%. Again, this will teach you the understanding of the prognostic factors and risk group stratification. The patients with bulky nodal disease, patients with extranodal extension, the patients with multiple positive nodes, or the patients who present with aggressive histology, take a look here. The recurrence rate is high. This is the group where I would be more aggressive in evaluation and management of these patients with thyroid cancer. This is one of the nice study published by my good friend Greg Randolph, and I think this was published in Thyroid, showing the impact of nodal prognostic factors on the loco-regional recurrence. And take a look here, starting from less than 5 nodal metastasis to bulky nodal, larger nodal, or extranodal extension. The risk of recurrence in patients with more than 3 centimeter nodes or extranodal extension is almost 70%. Those are the patients who will be benefited with aggressive surgery, aggressive post-operative follow-up, and aggressive adjuvant treatment. Now, let me bring up the debate. Where did it start? It started in 2006. What happened? The American Thyroid Association published the first guidelines. Actually, they were the extension of the guidelines which were published before. But again, we refer them to as the first guidelines because that was the time when the committee sat together and gave a major publication. In 2006, they made a statement, recommendation number 28, routine central compartment dissection should be considered in patients with papillary thyroid cancer. Keep in mind, it was written should be considered. What happened then? All the thyroid surgeons jumped on the bandwagon of doing central compartment dissection. The endocrinologist told us, this is thyroid cancer, do the prophylactic central compartment dissection so we can find a microscopic disease. Also at that time, the staging system was such that these older patients above the age of 45 were upgraded to stage 3. What we realized soon after this, from 2006 to 2009, we realized two things. Number one, finding the microscopic disease at level 6 or level 7 had no importance. We know almost 30% of the patients have microscopic disease, but the risk of recurrence ideally is only less than 2 or 3%. Our data and data from Providence and many other institutions in the world showed the risk of recurrence is very low. So finding a microscopic cancer by doing prophylactic neck dissection was not important. Number one. Number two, we also switched our philosophy of treating them routinely with radioactive iodine. And number three, which is most important, we realized soon after, the more prophylactic node dissections we did, the more complications we had. We had more nerve palsies, temporary and permanent, and we had more temporary and permanent hypoparathyroidism. So without giving any benefit to the long-term outcome, we were hurting more patients. And this is a classical story of the guideline changes. In 2009, the guidelines changed. And we realized that we don't need to do routine central compartment dissection. I'm going to build a case against the elective central compartment dissection, and that is, there is no survival or difference or the risk of mortality or recurrence with routine or non-routine central compartment. We talk about central compartment after 2006, but we didn't realize, is it unilateral or bilateral? Imagine you have done a bilateral central compartment dissection and the nerve is weak on both sides. The patient will wake up with airway problem or airway distress. Is it the recurrent laryngeal nerve above or below? Is it lymph nodes lateral or medial to the recurrent laryngeal nerve? What are the boundaries of central compartment? And at that time, level 7 was described in the 7th edition of the staging system, which was total confusion. Nobody knew exactly where 7 begins and level 7 ends. It was described as a relation between the sternal notch and the innominate artery, but no surgeon ever takes out the lymph nodes in the paratracheal area and describes this is level 7 or level 6. It was a glob of tissue that was removed, and we realized soon that it has no importance in the management. This was one of the study from University of Michigan, where the prophylactic central compartment dissection was quite popular, but they showed whether you had done a total thyroidectomy or total thyroidectomy with central compartment recurrent, central compartment dissection, the outcome was the same. The thyroglobulin did not change, the long-term survival did not change. So we developed a philosophy that addressed more to the grossness of the disease, and I like to change it from central compartment dissection to what I feel strongly, central compartment evaluation. And I'll show you that in a minute about it. Now, the question always comes, is when the patient recurs, which happens in about 2 to 3%, is the reoperative surgery more dangerous or difficult? And there are several publications in the literature, including the classical publication by Gary Clemen, that there is no difference whether you do initial central compartment dissection or the dissection is done at a later date. Remember, very important, the close monitoring and follow-up is very critical with appropriate evaluation if there is a recurrent disease with a CT scan. Now in 2009, only 3 years after the first publication, the ATA changed the guidelines. And they said, you do the prophylactic central compartment dissection only in aggressive thyroid cancers. If the tumor is large, more than 4 centimeters, gross extrathyroidal extension or bad histology. And that is very, very appropriate, and it is practical for every thyroid surgeon. When you see a big tumor, an aggressive cancer, you're going to be more aggressive. And as I mentioned before, I would spend more time in detailed evaluation of the central compartment. If there are suspicious lymph nodes, get a frozen section. And why I say this so common, emphatically, the Hashimoto's disease is very common in the United States, and a large number of patients with Hashimoto will have enlarged lymph nodes. They are confusing. And if you believe in prophylactic central compartment dissection, you're going to do much more dissection, injure the parathyroids and the nerves with no benefit to the patient. I would rather take a big lymph node, send it for frozen section. If it is benign, you're done. You know that the remaining lymph nodes are not of concern. Or if it is positive, then I would do a good clearance. And now they have recommended total thyroidectomy without prophylactic central node dissection should be the appropriate treatment in smaller tumors or T1, T2, what we popularly call as low-risk thyroid cancer. Again, remember, the guidelines do change. They change based on the current information available. They change based on the committee members, and they change on the aggressiveness of some of the committee members and dogma of some of the people involved in this decision making. Now, the consensus statement in 2009 came up here. They came up with the guidelines regarding unilateral, bilateral. There is still a lot of debate about contralateral nodal dissection, and there are a large number of publications from other parts of the world, especially in China and Korea, about the management of contralateral neck dissection, central compartment dissection, which obviously will put the patient into higher risk of permanent hypoparathyroidism. Just to summarize the guidelines, there is no good evidence that routine elective central neck dissection improves the prognosis. The ATA guidelines provide a rational approach to managing the central compartment based on available evidence or the lack of evidence. And the ATA consensus statement is very important. And the new ATA guidelines in 2015 adhere to the philosophy in 2009 that routine central compartment dissection should be used only in selected patients, larger tumors, aggressive histology, or gross extrathyroidal extension. I won't go into details about the central compartment dissection's arguments in favor. The arguments in favor are there is a large number of patients with microscopic disease, and in the past we upstage these tumors. We don't upstage them now. We keep them in the same stage group. The other indication was that some of these patients may need radioactive iodine. We don't use radioactive iodine routinely now. Up to 5 lymph node metastases, we don't use radioactive iodine. And these are the arguments in favor. There are arguments against that. And this is the classical publication from the American Thyroid Association guidelines. You will see here arguments against are increased risk of complications, hypoparathyroidism. And if you wait for a few months or a few years and the patient does recur, which you can predict on the first operation, the large tumor, aggressive nature, you think that this patient may recur with central compartment recurrence and be more aggressive. And the new ATA guidelines did talk about the central compartment, and they suggested, you can see here, no central compartment dissection for low-risk thyroid cancer. Strong recommendation. Take a look. The central compartment, if there is a positive disease, yes, you will do the central compartment clearance. In larger tumors, you may consider central compartment clearance with a weak recommendation. And I think the ATA must get a lot of credit for revising their philosophy about central compartment in the guidelines in 2009 and subsequently in 2015. What is our approach at Sloan Kettering and my personal philosophy about management of the neck in thyroid cancer? If the neck is negative, what do? I think I give a lot of thrust and emphasis on central compartment evaluation. And that's why I have written here, look for the tracheoesophageal groove nodes. The first job of the thyroid surgeon, when you mobilize the thyroid, to look for the paratracheal lymph nodes, central compartment lymph nodes. If it is enlarged or suspicious, I take it out, send it for frozen section till I'm doing a lobectomy or total thyroidectomy. I know if this node is positive, I may do something more. Look for the entire central compartment. Look for the mediastinal lymph nodes, level 6, level 7. Look for the Delphian node, which I'll talk to you in a few minutes. If any of these nodes are suspicious or enlarged or positive on frozen section, do the appropriate central compartment clearance. Otherwise, there is no need to do anything to the central compartment. What about the lateral neck? We don't do the berry picking operation. That was an old operation, was very popular once upon a time. We don't do that because the risk of recurrence is higher in this group. We do the classical modified neck dissection. Some people call it compartment-oriented neck dissection, functional neck dissection. These are the important structures in the neck, like sternomastoid, internal jugular vein, and accessory nerve, and no need to dissect at level 1. Very important changes in the management of lateral neck. Some tips about the neck dissection. This is not the incision we use. This is a J-shaped or hockey stick incision. Now we use the incision along the cricoid cartilage in a curvilinear fashion, what I call a necklace incision or C-shaped incision. This is good on both sides. You can go to the higher level, lower level. If you make an incision like this, it heals best, and it has the anatomical understanding of the skin creases of the neck and the blood supply to the skin of the neck. Some practical tips before surgery: always look at the preoperative imaging. If there is a CT scan, spend time looking at it yourself. Now, if the CT scan was done, it should have been done with a contrast, otherwise it is useless, it doesn't help much. But if you have done a CT scan with contrast, I'm going to give you a surgical tip. Always look at it yourself to see if there is a retroesophageal innominate artery, what we call as arteria lusoria. If it is present, you know that this patient has non-recurrent right nerve. And be very careful for those patients because you may injure the nerve not knowing that this patient has non-recurrent nerve. Review the tracheoesophageal groove area. Look at the vocal cords preoperatively. Identify the accessory nerve, and you don't need to go above the accessory nerve in these patients. Where do we miss the nodes? Look at the jugulodigastric area. Go right up to the submandibular salivary gland, find the digastric, and at the crotch between the internal jugular vein and the digastric muscle, look for the nodes. Do not dissect above the salivary gland or on the surface of the salivary gland because you are likely to injure the lower division of the facial nerve. Look for the supraclavicular and retrojugular lymph nodes. This is very important. Now, be very careful on the left side because you have a higher risk of chyle leak and chyloma, which is, to me, one of the worst complications if there is a severe chyle leak. Now, I already talked to you about the data from Memorial. This is the Delphian node metastasis data from Memorial. We published this several years back. We have an update on this, and we found the incidence of Delphian node positivity in 25% of the patients. Interestingly, we are now finding some of the patients who have recurred in the Delphian node area. So I always look for the Delphian node. Quite often I get a frozen section on that node. If that is positive, I'm a little more aggressive, both in the thyroid and in the paratracheal area. Even though we don't have a robust data on this, my feeling is the patient with Delphian node positive or positive Delphian nodes are at higher risk of paratracheal or more central compartment nodal metastasis. Don't forget about the complication with the paratracheal dissection, more nerve injuries, more hypoparathyroidism, the coil leak, the nerve injury, and don't forget about the Horner syndrome, which can be very distressing in women. When the eyes are not symmetrical and there is a drooping of the eye, the woman will not like that. What about the sentinel node biopsy? There are about 15-20 papers in the literature from Canada and Europe where sentinel node has become very popular. It can be done with a blue dye or it can be done with a radionuclide material. Again, we know where the lymph nodes are. So it does not make difference finding the sentinel node. You know where they are. The sentinel node evaluation is more important when you don't know which nodes may be involved. But I don't think there is a great future for sentinel node biopsy in thyroid cancer. What about the rising thyroglobulin? When there is a rising thyroglobulin after initial total thyroidectomy, there is always a concern about recurrence. And the recurrence should be evaluated completely. Do the appropriate localization study, and the best study is ultrasound and ultrasound guided needle biopsy along with a CT scan. Most of those patients will come back to appropriate neck dissection or the clearance of the central compartment. And again, one needs to be very careful about the optimizing the time of preoperative surgery. If the lymph node is below 1 centimeter, don't be in a rush to operate on that patient. At the time of surgery, there is scarring and fibrosis, and you may not find this lymph node that you are looking for, which is below 1 centimeter. And I am going to go back to my philosophy in surgery. Good judgment comes from experience, but the experience comes from bad judgment. I'm going to show you this slide because this is my own creation of what we call as a full circle in surgery. You know, there is a full circle in medicine all the time. We do something, we change it, we drop the idea, we go back to that again. And as my grandmother would say, if you treat common cold or flu, it stays for 7 days. You don't treat it, it stays for a week. She's very smart. She's absolutely right. And this is my philosophy about the central compartment. At one time, there was a lot of interest in elective and radical neck dissection. We did a lot of radical neck dissections for thyroid cancer. Soon we realized that it has no prognostic implication. We switched to only therapeutic neck dissection. Now we debate about the central compartment. We need a debatable issue in thyroid. That's why we debate about central compartment, level 6 nodal metastasis. Now, during my training, there was only one way we followed these patients. We did the clinical follow-up. Now we go for the ultrasound, we go for the thyroglobulin, and before they walk in your office, they know their tumor has come back, they push you for another surgery. Not right. This is the full circle. And job of a good thyroid surgeon is to break this circle and say, I'm going to do it based on the biology and the implications of the recurrence in thyroid cancer. If you look at the micrometastasis, it does not have any impact. If you look at the mini metastasis below 1 centimeter, no impact. If there is a major metastasis or large volume metastasis, it has some impact in future recurrence or future surgical intervention. This is the data that I was mentioned before from Providence, Rhode Island. The risk of recurrence in 304 patients in the central compartment was less than 2%. And Ian Nixon from our institution published our risk of recurrence was same, 2% in the central compartment. The PET scan has an importance. Again, if the recurrent disease is PET positive, I would be more concerned because those are generally more aggressive tumors and they don't respond well to radioactive iodine, and I would be more aggressive in the surgical approach in these patients. Some tips about the recurrent disease. This is a frequent problem. it may be difficult to find the disease. Again, as I mentioned, if the tumor is less than 1 centimeter, don't be in a rush to operate. Sometimes it is nice to have the tumor grow because you can find it. The worst thing you do is you do a neck dissection, take out a bundle of lymph nodes and find out there was no disease. You missed the tumor. And the radiologist repeats the ultrasound and says, the lymph node that we saw 6 months back is still present. There is nothing more humbling and distressing to the surgeon that he couldn't find the disease that he was aiming to take out. That's what I call as missing lymph nodes. And again, it does not have a major impact on the prognosis, and keep in mind the higher incidence of complications. The recurrent neck disease, is it a scientific reality or is it an iatrogenic problem? We created this problem. I told you what we did 20 years back. We didn't do anything. They were happy. We were happy. They lived with the recurrent cancer. Now we found the technology, and this is what I call as an iatrogenic problem. We are the victims of technology. Technology has a major impact when it suits to the biology of the disease, our understanding and our intervention. It has a bad impact if we use it ad lib or without scientific basis. And that's why, is it a scientific reality or is it an iatrogenic problem? We need to develop a balance between the risk of the disease and risk of the treatment. And as I mentioned before, let the treatment not be worse than the disease. This was one of the editorial I wrote many years back, some 11 years back, about the prophylactic central compartment dissection in surgery. And take a look at this. Recurrence in the low risk group requiring central compartment reoperation is quite rare. How often? 2%. And in the high risk group, it is probably unavoidable. And again, who are the high risk? We know those patients very well. And most important thing in surgery is first do no harm. Primum non nocere. That's the principle of management of thyroid cancer. I want to conclude with the last few slides. The good physician treats the disease, but the great physician treats the patient who has the disease. And I think this is the statement by William Alsner, so true in the management of thyroid cancer. And again, I'm going to say, let the punishment fit the crime. Let the treatment not be worse than the disease. There are some newer ways to manage these patients. A lot of interest now in the radio frequency ablation. We have very little experience. There is some good experience from Korea, some experience from Brazil, little bit of experience in California, Stanford Institution, but probably not a big experience with recurrent nodal disease. A lot of experience with alcohol injection. I think this was popularized by Ian Hay at Mayo Clinic. They have a huge number, but again, not duplicated in the rest of the world. There is limited experience, a lesion that the patient does not want to go for surgery or had multiple operations, and you are afraid you may not find the disease, or it is the patient has multiple comorbidities. Alcohol injection is a good choice. I do hope in the last 20 minutes I have not confused you, but again, if I confuse you, I've done a good job. I'm going to skip this slide because we talked quite a bit about it. I just want to leave you with this message. Patients with multiple positive neck nodes with papillary cancer may have additional lymph nodes. As I told you, if somebody has 15 nodes, there is a 16th node hiding. It's only the time that will show you that node. Be very careful. There may be additional nodes and you may not get a biochemical cure. The patients may stay with persistent hyperthyroglobulanemia. And we learned this very well in medullary cancer. The persistent hypercalcitonemia is very common in patients who present with advanced medullary cancer or bulky nodal disease from medullary thyroid cancer. I just want to show you these couple of slides and then I'll conclude. When you come to the operating room as an attending surgeon, what do? Adjust the light, adjust the position of the patient, put on the new drape, make an incision bigger, and what the surgeons like to do most commonly is complain about everything. That's the middle name of a surgeon. We love to complain. We love to debate. We love to bring up our own philosophy and dogma. During the difficult part of the operation, what do you do when the tumor is stuck to the carotid artery? Leave the operating room. Go for an emergency phone call or emergency visit. During that time, the fellow will do a good job and take the tumor out, or he will make a hole in the carotid artery, go and fix the hole. That you would have done by yourself anyway. Publish the results before the tumor recurs. Very important. And that's why it's very important when you see a bizarre case or a difficult problem, write the manuscript first before the pathology report is ready. And my last one, I'm going to conclude here. When you don't know what to do in the operating room, use irrigation. And when you don't know what to do in the ICU, use steroids. Thank you very much and have a great day.